Conventional parotidectomy achieves safe tumor clearance but often leaves visible scars. This presentation introduces the concealed mini incision parotidectomy or CMIP, which improves cosmetic outcomes while maintaining oncological safety. The modified Blair incision, though effective, leaves a noticeable scar. CMIP uses retrotragal and post-auricular sulcus incisions hidden in natural creases to provide tumor clearance with better cosmesis. The incision begins in the retrotragal groove and curves into the post-auricular sulcus. Skin flaps are elevated to expose the gland, preserving natural contours and minimizing visible scarring. Dissection is performed using a cold instrument or bipolar cautery vertically along the anterior surface of the tragal cartilage until the bony anterior wall of the external auditory canal. From here, the dissection is preferably done using a blunt instrument. Dissection is to be done vertically along the anterior surface of the bony EAC. The next bony structure, which is the only bony landmark present immediately deep to the bony EAC, is the base of the styloid. This can be easily identified. This forms the upper point of the tri-point landmark. Now, the posterior belly of the digastric muscle is identified deep to the sternocleidomastoid and followed to its origin from the mastoid tip. The superior border of the origin of the posterior belly of digastric from the digastric notch of mastoid process forms the lower point of the landmark. The area in between these 2 points houses the facial nerve and was less than 1 centimeter in all cases. Care should be taken not to cause bleeding that may cause visibility poor. The emergence of facial nerve in between the two structures is similar to the central prong of a trident. Careful dissection in the direction of the central prong of the trident will help identify the facial nerve. Once the main trunk of the facial nerve is identified, the rest of the dissection is similar to a routine parotidectomy, tracing the divisions and further branches of the nerve. The trident sign has been described as an easy and safe method in facial nerve identification in parotid surgeries in this paper, as is evident in the cadaveric dissection. The outcomes based on House-Brackman 2 and above and visual analog scale show that the CMIP is an excellent option for parotid surgery. Scars are concealed within natural creases and facial nerve preservation rates are comparable to conventional surgery. Patient satisfaction is consistently high due to improved cosmesis and preserved contour. Recently, we have foregone the tragal incision also, which improves the cosmesis and causes less problems related to cartilage. In summary, CMIP offers a safe and cosmetically superior alternative to traditional parotidectomy. It is better suited for benign and select malignant tumors, combining oncological safety with patient-centered outcomes. Thank you for your attention.